With regard to this webinar, I'm going to cover many aspects of Kienbock's disease, look at some of the basic science aspects, an algorithm that we've been involved with the development of, and so I hope that you find that of some use. I'd like to acknowledge David Lickman with some of the involvement, particularly with the algorithm, and Simon McLean from New Zealand, particularly with some of the aspects of the new advancements with 4D CT scans. So when we look at Kienbock's disease, I think more and more that it's really a mechanical condition, as we can see with the fluoroscopy and CT. We know from arthroscopy that we're likely to have issues with regard to the articular surface, but also it's basically comes down to some predetermined factors of the anatomy of the lunate. Interestingly, the venous drainage, I think, is more important than the arterial supply and the concept of compartment syndrome of bone. So we'll go through some of these aspects. We'll also talk about the role of arthroscopy, which is probably my biggest contribution here. We've looked at the non-functional articular surfaces, which are regular, and we've used this to put this into a classification depending upon which aspect of the articulations involved. And this algorithm that we developed with David Lickman, where the age, where the patient is young, does well, or very old, they're probably best not needing surgery. Then we look at B, which is the bone of the lunate. So we then look at if the lunate's intact, maybe we should do an unloading. If it is compromised, maybe we look at some sort of reconstruction. And finally, if the carpus is involved, then we need to look at a motion preserving procedure. And the final part of the talk will be looking at Kienbock's disease and how really it's probably another form of carpal instability as to how the ligaments all work and how they contribute to the type of failure that we see in Kienbock's disease. So most residents would be aware that there's a number of factors that predispose to patients with Kienbock's disease. So this would include a patient with a negative ulnar variance, a small lunate, a type 1 lunate as described by Steve Vegas, and often it's what we would call uncovered. So we can see this aspect of the lunate is articulating with the radius, but this entire aspect here is not covered on the radius. So we think that's an important factor. And there's some variability about the inclination of the radius, which is described in the literature. So I think one of the contributions we made was looking at the basic microanatomy, where we can see with these amazing images, we can see the structure of the lunate in true detail. And we can see this subchondral bone plate proximally. We can see these spanning trabeculae that span to the top. And these spanning trabeculae are really holding up the distal subchondral bone plate and the capitate and maintaining the height of the carpus. And this is a patient who presented to me probably one of the more early forms of Kienbock's disease that I'd seen. And we can see that there's this fracture coming across. It's a subchondral fracture. It's a little bit like the crest fracture that we're familiar with in Perthes disease. So we think CT scans are an important part of the assessment because you can't see this sort of detail without a CT scan. As we look through here with this fluoroscopy, this is actually a normal wrist, but it's got a type 1 lunate. And I really wanted to show how this cantilever effect of the ligaments pushing on the lunate, and it goes just over the top. And there's this area where reproducibly the forces are applied on the proximal aspect of the lunate. As we can see here, we can see that the radial aspect of the lunate is articulating with the radius, but this other ulnar aspect doesn't articulate, and there's a shearing force at this particular point from that cantilever. So if we take this clinical case I've just shown you, we put our micro CT image on there, and we create the capitate pushing on it with a nutcracker effect, you can imagine how this sort of fracture might occur. And in this dry specimen from the anatomy lab, interestingly, there's actually a microfracture in the proximal aspect of the lunate. So I expect this patient didn't die of Kienbock's disease, but we can actually see that sort of microfracture in the proximal aspect of the lunate. The other thing is, this is amazingly thin. It's 0.1 of a millimeter, and the engineer that we work with on the micro CT, I showed him these images, and I said, how thick is that? And he said, well, it's 0.1 of a millimeter, or 100 microns. And I looked at him and asked him how he knew that. And he said, well, that's the thinnest bone can be. And so the single layer of trabeculae goes down to 0.1 of a millimeter or 100 microns. So we think the capitate tends to punch in onto the lunate, and we can see this coronal type of fracture. And interestingly, we can see the capitate in this axial image, how it creates this fracture across the lunate, and we can see how it propagates towards the triquetrum. And there's this other fracture in the sagittal plane that spans out from the ulnar edge of the radius. So these are not uncommon types of configuration of fractures that we see in clinical practice. But really, we've noticed that there's quite a number of different types of fractures that we see. And obviously, in more complex cases, there may be fractures in all sorts of planes. And interestingly, we see a reabsorption of the bone. And in some cases, like this proximal row carpectomy lunate that we've done, we can see there's basically no bone in there at all. And so there's quite a spectrum of cases that we see with the different types of fractures. This was another lunate that we removed as part of the treatment with a proximal row carpectomy. The interesting finding to me was this massive area of reabsorption in the endosteal bone. We can see distally that pretty well all of the bone is still present. There may be some loss of the proximal articulation, which of course affects how the wrist would move. And of course, there's collapse of the entire lunate structure. This is another lunate that we removed, and we can see here the proximal aspect of the lunate. Interestingly, this is the endosteal bone. It's like the honeycomb of bone, and you can imagine that this is just not designed to take any of the load across the carpus. And this fine bone, I think, just sort of breaks down, just like honeycomb would if you were pushing on it. And so this is the reason why I think a lot of this endosteal bone becomes reabsorbed. So every textbook ever written about Kienbock's disease always talks about the arterial supply, and Lee and Gelberman have written the two most important papers, and they highlighted that there may be a single vessel, and in some cases there's no anastomosis, and it's postulated that these are factors as to why a patient may get avascular necrosis. Interestingly, a surgeon called Harry Crock from Melbourne, Australia, he did some amazing work on the vascularity of the entire body, but also of the lunate. And one of the things he stated was that whenever an artery goes into bone, there's also always a vein there. And he did some interesting work. Sorry, I'll just go to this first. So this is Rainer Schmidt's work on intravenous gadolinium enhancement. So what he's done, in fact, he's put a normal MRI, and then he's given an intravenous injection of gadolinium. And then you can see how this lights up, demonstrating that there is perfusion of the lunate. And this is his classification, demonstrating whether there's perfusion or whether there's necrosis. And it's certainly a very useful concept. And for those who have a real passion for performing vascularized bone grafts, I recommend that you read his work, and you should consider using intravenous gadolinium as part of your assessment. So going on to Harry Crock's work, as I said, this is the venous drainage of the lunate in a cadaveric model. And he stated that wherever there's an artery going to the bone, there's also a vein. So if I stylize this with PowerPoint, we can create where the veins probably are. And one thing that he stated was that there was this subarticular plexus, which is a set of parallel veins on the very proximal aspect of the lunate. Interestingly, this is not typical just of the lunate. It occurs in the knee, it occurs in the patella and other parts of the bone. And so the important thing is that there are parallel veins that all run in a plexus. And I couldn't help but think that that must be important and may be a reason as to why patients get avascular necrosis. As you would know, the venous plexus in the entire body tends to be a crisscross network. And so if one part gets obstructed, then another part of that network can take the venous drainage. And I think that's actually why there are vena comitantes next to an artery, so that if you obstruct one of the veins, the adjacent vein can take over so that you don't get obstruction. So if we look here and we get this stress fracture in the proximal aspect of the lunate, we're going to end up with a localized area of venous hypertension where the veins can't drain, Or alternatively, if we get an obstruction of one of these veins as it passes out of the lunate, we may get generalized hypertension, venous hypertension of the entire lunate. And if I put these images together, this is Harry Crock's work, this is our micro CT, we can see how the veins may pass through the subchondral bone plate in that adjacent area. And this is Harry Crock's work, which demonstrates this vein sitting adjacent to the subchondral bone plate. Like, it's incredible. It sits in like in a gutter on the bone. So these curves in the bone, which we don't usually appreciate, they have large veins in them. And this is where the fluid drains. You can see a fluid level here. So clearly it was actually up the other way as part of the process. And then you can see in this example on the bottom right, this longitudinal section of the bone next to the subchondral bone plate. And you can imagine a fracture of the subchondral bone plate would lead to an obstruction of the venous drainage and lead to localized venous hypertension. So the lunate's basically a compartment of bone. And we know that the arterial pressure coming into the lunate is about 60 millimeters of mercury. And it has a significant arterial inflow. It goes into a set of sinusoids and there's venous drainage. The venous drainage has a pressure of about 5 to 10 millimeters of mercury. So it's really quite low. And we know from some work of Jensen, if you put the wrist into extension, or if the patient has Kienbock's disease, the pressure inside the lunate will increase. And interestingly, in patients with Kienbock's disease, he identified that the pressure can go up to as high as 150 millimeters of mercury. So the venous pressure concept, I think, is an important one. Now, if we have ischemia in the bone, the fat cells in the bone marrow are very sensitive to any ischemia. And the effect that that has, that these fat cells will tend to swell up. And when they swell, then that can lead to further venous obstruction. I think this whole concept of compartment syndrome of bone is a critical factor as to why patients get avascular necrosis in the lunate and probably other bones as well. We've looked at these concepts also in the capitellum of the elbow, and we believe that they hold true. So there's a number of factors here. There's ischemia to the fat leading to venous obstruction. And we know from those of you who do reimplantation, you're always worried about the venous drainage. If you obstruct the venous drainage, you can lose that finger. It's quite hard to obstruct the arterial inflow, but the venous drainage is easy to obstruct. And so we developed this summary of etiology of Kienbock's disease. So we know there's a motion of the wrist, and we can see the arteries and veins. We know that there are forces that are applied onto the lunate. So we have this compression and a shear force here. We know that there's this sort of nutcracker effect, and the ligaments will, of course, have a tension. And that we think there are associated fractures that typically occur, such as the subchondral bone plate fracture, the coronal fracture, and these sagittal fractures. These demonstrate some of the typical fractures that we've seen. And interestingly, we've also seen cases with ligament avulsion, such as an avulsion of that bone of the lunate. So we have these mechanical aspects, as we've demonstrated with fluoroscopy and CT. We've talked about arthroscopy. And I really think the primary osseous anatomy, the venous drainage, and also the concept of compartment syndrome of bone are critical factors in the development of Kienbock's disease. So I'd like to go on now and talk a bit more about arthroscopy and try and bring this back into the clinical realm. I'd like to acknowledge Simon McLean has been involved, particularly with the more recent review of our results. So if we have a look at this example on the top left of a patient with Kienbock's disease, we can see that this bone's exposed, it's irregular, there's clefting. We would refer to this as a non-functional articulation. If we look at the image on the bottom left, we can see that the articulation is smooth, it's glistening, it feels normal. We would refer to this as a functional articulation. This is another example where there's ulceration and sclerosis. Clearly, this is not going to be a very functional unit. And so we developed and published in 2006 a classification based on these. So for example, if this lunate facet was irregular, as seen here, it might be this type of example where it's a 2A, where the lunate facet and the proximal lunate are involved. If this is normal and this is normal, well, then that would be a grade 0 and so on. So we can define in the central column which articulations are involved and try and use that to help direct our treatment. Interestingly, every case that we saw had associated synovitis, and as a consequence of this, synovitis itself is not a diagnostic criteria using that classification. So we developed principles of treatment so that you'd either remove some of the articulations or fuse it or bypass. So the aim was to leave all articulations in the joint that are normal, so there's no abnormal articulations, and leave the patient with a motion-preserving procedure. This was the concept that we developed all those years ago. So for example, a grade 0 where the lunate is basically intact, well, maybe there's a role for a vascularized bone graft or osteotomy such as an unloading procedure, sometimes a synovectomy or even a farage of the lunate, which is drilling of the lunate. There also has been described farage of the radius and interestingly farage of the capitate. So the role of farage certainly in the hip is well described, particularly for the earlier phases of avascular necrosis. And then if we go on to the type 2s, there's two type 2s. That would be a 2A, which involves the proximal lunate and the lunate facet, and then when there's a coronal fracture of the lunate. So in these cases, we've had cases where we performed a radioscaphoid lunate fusion, and at first, this doesn't seem to be the right thing to do, but if you debride a fair bit of the proximal lunate and the scaphoid, you can bring the whole thing down, but you must have a normal articulation of the distal lunate. We performed proximal row carpectomies, and in all of the cases that we've done this, the patients had a good outcome and did not require revision or any salvage procedure out to 10 years. So we've more recently published the results of our long-term outcome using this algorithm. We prospectively identified the cases. We had outcomes we thought were good, and it was rare to perform a salvage procedure. There were some cases where we found some interesting findings, such as what we called a concealed fracture, which is where at first it doesn't look too bad. You put the probe in there and there's a fracture that you can almost unravel. And so this is an important point. And some of these cases, in fact, ultimately led to a poor outcome. And so we need to be aware of that. The other point that was interesting was that the patients who just had an arthroscopic debridement didn't do quite as well as we would like. And I think it's related to some of these fractures that probably did affect the stability of the entire lunate. The debridement probably improved their pain initially, but the patient still had some progression of the natural history for the lunate to become, to collapse. So this is such an example where we can see there's a considerable DISI configuration. We can see there's comminution, and we can see that the fracture extends from the proximal to distal aspects of the lunate, and also it's quite wide. So if you think about this fracture, when you first look at it, you think, well, maybe that's sort of okay, but it's affecting the carpal stability, it's affecting the integrity of the entire lunate in a number of aspects. And after a period of 1 year, despite a debridement in this patient, the patient required revision surgery. This was their lunate. We can see it arthroscopy. This was the initial view of that, which at first just looks like there's a crease. But once we were able to probe that, we could see this concealed fracture, which probably reflects this here, was involved. And at 1 year, we've done a proximal row carpectomy. So I'd like to now go on to talking about the algorithm and classification system that we've developed, particularly with David Lippman. And basically it comes down to A, which is the age of the patient, B is the bone, which of course is the lunate, and C, which is the carpus. So what you may see when you see your patient, you may classify them with Lippman's grade. You may use the vascular classification of Schmidt, as we described briefly, or you may use our articular cartilage classification. Or that's how you may see, and as part of the way that you interpret the patient that presents to you. You may look at using these classifications that help define the osseous, vascular, and articular aspects of Kienbock's disease. And what we tried to do was interpret how these aspects were affected in the lunate, bringing together these three classifications, and then trying to create something that was a new concept of Kienbock's disease that respected all three factors as demonstrated, but not just of the lunate, but of the entire wrist. And so this is to consider the lunate and the entire wrist I'd like to acknowledge David Lippman as a co-author in this concept, and the textbook that we published on Kienbock's disease probably 5 years ago now, we developed this concept. There have been further publications we've had on that since then. So basically the summary of this is the age is important. We know that a patient with Perthes disease has a good outcome. We know that a patient less than 15 or less than 20 has a good outcome. And we know that those who are older than 70 actually often have x-rays that don't look so good, but in fact, the patients actually do quite well. So this group of A, the age of these as defined here, tend to do well, and we would recommend certainly a prolonged period of non-operative treatment before proceeding with surgery. So then we go on to B. So this is principally in the age group of between 20 and 70. We look at the type of the lunate. Is the lunate intact? Does the lunate look pretty good? If the lunate looks good, well then let's protect it. Let's consider unloading it, and we would consider a radial shortening osteotomy or a capitate shortening osteotomy. If the lunate's compromised and there's some concerns about it, then we think about the concept of a multi-modal approach, which might be to do a shortening osteotomy to stabilize the STT or SC scaphocapitate and consider a vascularized bone graft. So this is what we would refer to as a multi-modal approach. And then once the wrist starts to become involved, once we start to get carpal collapse, then really we're looking at it in the same way as we might look at slack wrist or snack wrist. We're looking at a motion-preserving procedure such as proximal row carpectomy or a scaphocapitate fusion. So an important part of this whole equation or algorithm is us as the surgeons. What can you do or what can I do? So I think most people can do an arthroscopy and assess the articular surface. I think most people can do an osteotomy. Vascularized bone grafts are a little bit more complicated, proximal row carpectomy and limited wrist fusions. So I see these as the procedures that all of us really should be able to do as hand surgeons. Then there are some other more complex things. And these more complex things probably should still be done in the specialist units, and they probably should still be under a university model of training and of review. So this is complex arthroscopic techniques, internal fixation of the avascular lunate, free tissue transfer such as from the medial femoral condyle, and implant arthroplasty such as lunate replacement, hemiarthroplasty, and total wrist replacement. All of these techniques are really advanced techniques, and in my opinion should still stay within the specialist units in those areas where people have the appropriate training. So we sort of use this simple stoplight concept, and for the training I think it hopefully is quite useful, and certainly for junior consultants, and it just helps give some direction as to where you might take your patient. So if we go to A, which is the bone, so if the patient has a good prognosis, so they're a younger patient, this Kienbock, then we know that those patients will do well. Although this lunate looks quite terrible, we actually know the patients actually do quite well. So we would look at non-operative treatment for probably at least 6 months. So, but if they fail that and they still have pain, if they're before skeletal maturity, there may be a place for piposodesis or even STT joint pinning. Although I must admit I'm a bit concerned if my son was to have this sort of problem to put the pins in his wrist, but I think it needs to be taken case by case. So effectively, we would look at these conditions, these operations in this limited group for those who fail non-operative treatment. So now we go on to the state of the lunate. So this is for an adult, say from 20 to 70, and we look at, is the lunate intact? Is it a good one? Is it compromised? Or is it just not reconstructible, something we really can't use? So if it's intact, let's preserve it, let's protect it. If it's compromised, let's consider reconstruction. And clearly, if it's no good, we need to look at a salvage procedure. So these are really very basic principles, and it's deliberately as basic as that, so that with time as we evolve, so it may be that we develop new reconstructive procedures in the future that are better, which enable us to change which cases we treat in different ways. So if the lunate is intact, and we're looking at a good lunate such as here, let's protect it. And so if the lunate, if there's a negative ulnar variance, then what we would consider doing is a radial shortening osteotomy, and this would be a standard of care technique. Then we look at if there's a neutral ulnar variance or even a positive ulnar variance, we can look at performing a capitate shortening osteotomy. These are sort of standard procedures. And the technique that we like to use now, which is a different way to what people have treated in the past, is what we call a single cut osteotomy. So this is deliberately just a single cut with an oscillating saw or one of these side cutting reamers. So the way that we recommend you do this is that you put a wire down and then a cannulated drill, take that out, and then perform the osteotomy. The reason we recommend to do the drilling first, it's a bit like when you pre-drill an olecranon osteotomy, so that you make sure that it's exactly in the right position. If you make this osteotomy first and then try and do the fixation, you may have some difficulty getting it all to line up. By doing it this way, it just lines up and it's actually quite simple. So that we can see how the brachioradialis will tend to contract that down. We then put the cannulated screw in. So that's a reasonably simple thing. And this is a professional tennis player. At 1 week, he's just given a splint. Because it's not a fracture, because the periosteum's not disturbed, it's not unstable or not extensively unstable, just one screw and a removable splint, and just tell them to slow down a bit. Those patients will do well, and this is going to heal because it's metaphyseal bone. So the other concept that we've used is to do it with a capitate osteotomy, and we use single cut osteotomy, and we have a publication on this which you may wish to refer to, and it's a little bit like when you do an osteotomy of the. Just want to go back. It's a little bit like when you do your osteotomy. It's a little bit like when you do internal fixation of a scaphoid and bone grafting. You take out a bit of the trapezium in the scaphoid. In the same way here, it's a retrograde technique. You take out a little bit of the base of the third metacarpal, and it gives you the perfect line. So you then go down, put your wire in, again, cannulated drill, take that out, use a narrow reamer and perform your osteotomy to enable the capitate to be divided. And it's important to make this a little bit more distal than you'd think. And the rationale for this is the vascularity of the capitate comes particularly from the volar side. So it's again like the scaphoid. And so these volar branches need to be protected to enable to ensure that we have vascularity, as shown here by Steve Moran in these beautiful images that he's developed. So we then put the cannulated screw into position, lock that down and compress it. And again, we only need a splint for this because it's reasonably stable. And this is an extra articular procedure. So therefore, they don't tend to get a lot of stiffness. We did start off putting screws from this way, but this then has the articulation, having the screw going across the articulation, which we don't like. But more importantly, you tend to hyperflex the wrist to get the angle. And we were concerned that we may end up with a lunate fracture. This technique from distal, we think, is a lot better than the other options. So once we've gone to the position where the lunate is compromised, so now we're concerned about how the lunate works, we're thinking about doing a reconstruction. And in specialist units, there may be a place for free tissue transfer. So how do we do this? Well, at arthroscopy, it's quite interesting to see these sort of cases. We can see that with traction, how there's the subchondral bone plate is just floating, and that we can then push it back up to this area where this defect is within the lunate. And in this lunate that we've taken out, this gives a wonderful insight to actually what's happening. We can see the articular surface doesn't look too bad here, but we've got this entire area of subchondral bone that's been reabsorbed. We can see this fibrosis and fractures. And the other thing that's very interesting, we can see these new pillars of bone, where Wolff's law is trying to reconstruct and make a new lunate in those areas. But clearly it's not going to work so well here. But in the younger patient, the ability to reconstitute part of the lunate is actually quite incredible. So there's many vascularized bone grafts that are available. The simplest one is the Horry graft, based on the dorsal first and second intermetacarpal artery. There's many techniques described, but I think this is the one that's the simplest. So the multi-modal approach is probably a new concept as well. So we may look at doing an unloading procedure. We may look at putting a K-wire in to provide some stability to protect the lunate, and we can consider using a vascularized bone graft. The interesting thing here about the multi-modal approach, at first it might seem a bit radical, But that's what we do with rheumatoid arthritis, with tuberculosis and cancer now. All of those conditions have treatments at various parts of the disease process. So we think the same thing applies here. And in fact, this concept is not new. Many authors in the past have also done this, but we've just labeled it so that we actually understand what we're doing here. So fixation of the lunate itself, a lunate fracture, and Mark Barrett's has provided me with this example here where he's put some K-wires in. You can see again, he has this scaphocapitate pin and he's done a radial shortening. So again, it's a form of multimodal treatment, and he was quite happy with the results of this. However, at this point in time, I'm not sure what the role of internal fixation of the lunate in Kienbock's disease. I think we need to get a better understanding of this, and it's no doubt important exactly the fracture configuration and also the perfusion of the lunate. So these are aspects that I think we need to get a better understanding of. Christoph Mutherland, in the more advanced cases where the lunate is very fragmented, has looked at resecting the lunate, which is as an arthroscopic procedure. So from a technical point of view for arthroscopy, that's quite simple. This is his image at 6 months. Some of the other cases where I've seen the lunate just excised do end up with ulnar translocation. So again, I think further work's required in this space. However, this is technically a simple procedure. So going on now to the carpus. So when the carpus is compromised, so the scaphoid often goes into flexion, we get considerable necrosis and collapse of the lunate. So there's a number of procedures that are commonly performed. Proximal row carpectomy, we know, is a good procedure for the younger patient, a good procedure for the older patient who is low demand. And we know the Scaphocapitate fusion is a procedure that's probably better for the younger patient who's a little bit higher demand. So I just want to talk briefly about Scaphocapitate fusions. So the concepts of Scaphocapitate fusions are very much the same as what we understand for STT joint fusions. And as a consequence of TT and capitate all being sort of together, the Scaphocapitate fusion does tend to provide this stability through the carpus. So, but what we get with the scaphoid being extended, so it's important to do that with this type of fusion. We get loading through to the lunate, to the scaphoid facet. We can see the sclerosis. And it's interesting to see that the lunate height has been largely maintained, and we get this unloading area here. So all the loading is now going through the radial column. So the reason to perform, in my opinion, to perform a Scaphocapitate fusion instead of an STT joint fusion is it tends to load up through the central column and through the radial column. So it comes up through the scaphoid, through to the capitate and STT joint. And I think that's better than having all the forces just go through the radial column. The role of arthroscopic limited risk fusions and using these advanced concepts are probably outside the scope of this talk today. However, Eva and PC Ho, I think, are really experts in this area, and there's wonderful presentations that we've recently done as part of IWOS and the American Hand Society. There's a whole webinar on these concepts which you may wish to look at. Now, I just want to finish up with our recent work, and I'd like to acknowledge Simon McLean for some of this. We can see here we've got this impaction of the radius punching in to the lunate. And then we've got this, we call it a radius template as it pushes into here. And it's interesting that we can see that how it's collapsed down the radial side or the lateral side of the the radial side of the lunate. But we've got this ulnar aspect or this ulnar pillar here that remains intact. And this is similar to what we know in the hip with Perthes disease and also the capitellum. So this pillar is probably important with Keembox disease as well. But we can see in this example, we've got this comminution of this pillar on the ulnar side, and this is going to lead to some collapse of that pillar. And then finally, we can see that now the radial side column is collapsed. And in fact, the ulnar column is pushing to the side, and we get this kissing lesion in this area. So the way that these columns of the lunate collapse will be important, and some of the work that we're looking at currently. The other thing that's interesting is if we have a look at this example on the top left, how the lunate moves backwards and forwards in this forward ECT, we think of this as internal lunate instability. So the instability is within the lunate itself. And we can see that the capitate is sitting more ulnar than it should be. And in fact, there's of the lunate as well. So there's some ulnar translocation of the carpus. And we've seen examples where the triquetrum is sitting completely on the ulnar styloid. So if we take this example here on the right, and we can see this is the axial image in a 4D CT scan, we can see where the ligaments are, and we can see that these ligaments are the attachment points on the bones, and the ligaments have been avulsed with their bony attachments. So the more we think about this, this is like an equivalent to scapholunate instability. So in the same way we talk about a Monteggia equivalent, this is a scapholunate ligament equivalent. This is Keembock's disease, intrinsic instability. So we look now at this early case, and we can see this fragment of the volar aspect of the lunate. If we now go to the same patient, and as they're going to radial ulnar deviation, you can see that this volar cortex is trying to be avulsed. It's being ripped off by the volar capsular ligaments. And so we think that this is a lunate fracture in progression. So it's happening, like it's almost like if he moves it another 10 times, he might get the fracture. So again, we can see how this is part of the type of instability that we're seeing right in front of our eyes with the 4D CT scan. So if we look at this volar fragment, as we've just seen, and we try and look at some other cases, so we can see as this wrist moves, this fragment's already broken. So it's avulsed. So it's gone from a fracture in progression to an avulsion. And this is another case where we can see this is actually completely off and it's taken a bigger fragment. And we can see how it's impinging and punching into the volar aspect of the radius. This patient has a very poor range of motion. And then if we go to the next case, we can see how it's really locked and stopped the whole wrist moving pretty well. So this volar fragment, how it progresses through these whole aspects, is a very interesting part of where we're trying to take the understanding of Kienbock's disease. So if we go on to this, and I'd like to acknowledge Simon's really nice paper that he's done with us in Journal of Hand Surgery. And so if we look at the what we would refer to as the nidus points, or main ligament attachment points of the wrist, as the wrist moves backwards and forwards, there's going to be lunate fragmentation, internal lunate instability. As David Lippman taught us, you get collapse of the radial column, and the central column's collapsing down as well. And these ligaments actually remain intact. They're not sort of gone. The ligaments are still there. They may have an avulsion of the bone, but they're still there. And this creates like a pseudo-laxity, the concept that we know of in the knee. So if you've got degenerative osteoarthritis in the medial side of the knee, then you can still straighten the knee. The ligaments are still all there, and it's a pseudo-laxity. It's not a true laxity. So we have a whole session on the American Hand Society, which we did on avascular necrosis. There's a whole lecture devoted to this concept, which you may be interested in. So sort of in summary now, so there's many aspects we've discussed. We've got the dynamic fluoroscopic aspects here, which we think lead to the mechanical components of Kienbock's disease. We've highlighted the importance of arthroscopy, but it really is underpinned with regard to the anatomy, the skeletal anatomy, the venous anatomy, and also the compartment syndrome of bone concept. Arthroscopy is important as a diagnostic and as a staging treatment option. And also we can do a debridement, forage, bone grafting. So in fact, I didn't mention this, but the debridement we'll do a forage, but it can also be done as a bone grafting through the same technique as our friends have done. And then we can lead to more advanced reconstructive techniques such as limited wrist fusions and proximal row carpectomy. So I think arthroscopy has an important part to play. The algorithm, age is important, a critical factor in all types of avascular necrosis. If the lunate's intact, let's unload it, consider a single cut osteotomy. If it's compromised, maybe a multi-modal approach. And finally, if the carpus is compromised, a motion preserving procedure to maintain motion and function and remove the pain. So there's a number of people that I must acknowledge, as I've shown here: David Lippman, Simon McLean, Harry Kroc, and also Dr. Yeo, who helped me with some of the work some years ago. And more recently, we've published on Greens Online a chapter on Kienbock's disease, which I think you'll hopefully find of some interest. So thank you very much for having me involved in this webinar. I hope it's been of some use to you, and we look forward to seeing you in London at what's going to be one of the best meetings in hand surgery. Thank you very much.